My name is Gethin Harris. I'm the AHP Person-Centered Rehabilitation Lead. Just a bit of housekeeping. Can I ask us to turn our microphones off, please, unless we get to a point where we can hopefully have a chat about with some additional questions between speakers or at the end with our panelists. Just to let you know that this session is going to be recorded and will be edited and then placed on our website at a later date as a resource. I think from a prehabilitation point of view, I think we're all aware of the challenges of the NHS with regards to high waiting lists, multi-morbid populations, and therefore we recognise that prehabilitation is a fantastic way to improve a person's physical and psychological well-being prior to an intervention, and hopefully allowing that intervention to be successful. It provides people, family and other stakeholders with the right information to be aware of choices and consequences of decisions made with regards to their health. And hopefully also it's a position where when prehab is done well, it's a position where people choose not to then go on for intervention and potentially free up specialist care and also in a position to leave their healthcare setting earlier. For me, this session has been quite a timely session in exploring prehab, especially after the recent best practice carousel session run by the Welsh Government Planned Care programme recently. I thought that was a great session for me and highlighted the use of differing health professions, not just AHPs, to reaffirm that prehabilitation is everyone's business as well. And that session gave us a wider lens of what's going on over the border in England. And it was great to hear also Rachel Barlow from Cardiff and Vale presenting in that session. We've got Rachel here, who's the clinical lead for rehabilitation in Cardiff, also helping out with the chat. So I'm sure there'll be loads of questions and we'll do our best to answer them, but we might not get to all of them. But I know Rachel, where she can, will be looking to help with some of those queries in the chat. Thank you so much for the information you guys have also filled in and completed. We'll be using though that information as sort of the 3-4 main key questions to ask our panelists at the end. Before that though, again, just to thank you, the main speakers. We've got speakers from Betty Cadwallader to hear about their prehab services and then a specific example of joint working as well with joint approach. And then we'll also hear about cancer services across Wales, and then specifically go to Hywel Dda to hear about a orthopedic example of prehab as well. Before we go into that though, I'm going to ask Abby if you can move to the next slide for us to have a short message from Ruth Crowder, the Chief Officer for AHPs in Wales.
Hello. I'm Ruth Crowder. I'm the Chief Allied Health Professions Advisor in Welsh Government. I'm really pleased to be able to support this event today, and I know that it will be extremely informative and generate lots and lots of ideas. The Allied Health Professions Framework seeks to support AHP's transformation of services, to improve our outcomes and enable AHPs to embed value-based care. We will need to extend and redesign our services to provide earlier and more effective support to improve population outcomes, as well as expanding our community-based interventions and community rehabilitation. This all aligns with a Healthier Wales and with the 4 national programmes. In particular, the Planned Care programme, which has identified the need to increase our provision of rehabilitation and services which support people to wait well. There is a vital need, as we support people who are going to be waiting some time for their care, that we increase provision of prehabilitation and ensure that people remain as well and fit as possible, both while they're waiting, but also because we know this has an impact on their ability to recover from that care once provided. Our services need to be multi-morbidity, well-integrated, person-centred and place-based, with a maximum flexibility and minimum handoffs. Such well-integrated services will be vital in the reset and recovery of health and social care services in Wales. I want to thank you all for your interest today. I'm sure it will be a highly successful and informative event, and I look forward to seeing how you implement some of the developments and ideas that you discussed today. Diolch yn fawr.
Big thank you to Ruth for that message. Abby, can I get you to move on to the next slide, please, if that's okay? Lovely, thank you. Again, thanking everyone who's completed a bit of information that was sent out earlier, just to understand the audience and the needs. So from the information that we did get from yourselves, it was quite clear that we've got roughly about 40% of people that are currently offering some version of prehabilitation, which is great. But more interestingly, it's sort of 90% plus of people that wanted to either progress prehabilitation in their area or develop it from a starting point. Looking at the list of people, generally we seem to have clinical leaders and managers, but great to see areas such as exercise rehabilitation and research as well also here today. I think people have described prehabilitation in their forms as a process of preparation, optimization, and opportunity to improve people's well-being. And generally, we're seeing that being run in multidisciplinary teams or program-based approaches. Benefits, as well as what's already been mentioned, I think improved outcomes, and actually interestingly about that, improved therapeutic engagement with the workforce, which and then creating that empowerment for the person. Challenges, which I think we'll probably explore again a bit later with the panelists, but access to training resources, that buy-in for workforce and the people using the services. I think seeking ideas on how to implement, and then that sharing of practice, which hopefully, obviously, there's a bit of a starting point from now and the recent carousel session with the Welsh Government. Okay, we'll move on to the next slide, please, Abby. And this is a chance now for Jackie and Rachel to upload their presentation. So Jackie is the AHP Cancer Lead in Betsy, and Rachel is in the same role in Hywel Dda, but we'll be talking a bit more from a Always Cancer Network point of view.
Lovely, thank you, Gethin. Can everyone hear me okay?
Yes, great, thank you.
Great, lovely, thank you. So Jackie's given me the impossible task of just giving me 3 minutes to talk about something that I'm very passionate about. So I apologise in advance, we'll go over a little bit, but I'll try not to. And I apologise, the dogs have just decided to go nuts in the background as well, which is always good on these national calls. So, as Gethin said, I'm Rachel. I'm one of the therapy leads working in cancer rehabilitation over in Hywel Dda, but I also work alongside a number of different therapy leads across Wales. Next slide, please, Jackie.
Yeah.
So I'm just going to briefly give you a little bit of an overview about why rehabilitation is really important in cancer and some of the work that's going on at the moment. Apologies, this slide hasn't projected very well onto the slide that we're using, but this slide just gives us a little bit of an idea or a starting point about why cancer, why prehabilitation is important in cancer. So a lot of you will know that the stat in terms of cancer is changing. We are now looking at about 1 in 2 people who are developing a cancer. The really good news is people are surviving much, much longer with cancer, which is fantastic. But the bad news of that is that we know that people are living for a long period of time with lots of consequences of their treatment. If we look at some of the stats in terms of what the population who are living with cancer at the moment, so across the UK, it was about 2.5 million people living with cancer across the UK, and we know this has increased by about 400,000 in just a 5-year period. And what that actually means for Wales is that if you think of the capacity in the Millennium Stadium, so I'm talking about the seats now, not the pitch area, but if we were to think about all of the number of people in Wales living with cancer, that would fill a stadium by about 1.8 times. So we're talking about a significant number of our population across Wales. And what we know, as I mentioned earlier, we know there's consequences of the treatment. We know it's having an impact on patients longer term. And this is actually causing pressure on our NHS at the moment. So we really want to start looking at new ways of working within cancer. Next slide, please. Okay. For those of you that did link into that session that Gethin mentioned earlier, Rachel Barlow, who's on the call today as well, did present a lot of data around the impact that COVID has had on our population. And we are getting stats through at the moment that we know the health and fitness of our cancer population is worse. We know that a lot of our patients during the COVID pandemic perhaps didn't get the support and advice that they needed from primary care. And we are starting to see the patients are presenting much later with more disease burden. We know a lot of our patients are sitting on waiting lists at the moment, which is the impact is that our patients are less fit before their cancer treatment, has a knock-on effect in terms of complications and impacting on their ability to recover after that. Next slide, please. Now this slide, I apologise, is really busy, so I'm not expecting you to be able to pick up all the detail from this. But this slide, I think for me, is a really useful slide just to demonstrate what our cancer patients go through. It's not as simple as somebody coming in needing prehabilitation for a one-off intervention. Our patients are going through multiple treatment modalities over a long period of time. So when we're talking about prehabilitation for cancer, we're not talking just about a one-off intervention. We are talking about optimising patients throughout their cancer continuum. So the slide that I've enlarged at the bottom, this is showing this is what a lot of our upper GI, so patients who've had cancer of the stomach, esophagus, go through. A lot of the treatment modalities at the moment are chemotherapy, followed by surgery or radiotherapy, followed by some more chemotherapy afterwards. So when we look at this slide here, the dotted line would be the functional capacity for those who don't have any prehabilitation. And then the main line then is the impact that prehabilitation can have for this cohort of patients. So as you can see, the aim would be improving or optimising physical function and psychological function before, during chemotherapy and before surgery. You will get a decline in conditioning during the surgical period, but then it's about optimising these patients and bringing up their function capacity again before they go on to the next treatment. Next slide, please. When we look at prehabilitation, we are talking about the four pillars. So we're talking about nutrition, exercise, psychological well-being, as well as looking at the healthy lifestyle factors such as smoking and alcohol cessation. Big word to say in a call. Next slide, please. So some of the work that's been happening across Wales over the last couple of years. So as I mentioned earlier, there's quite a few cancer AHP leads working across Wales. We also have Rachel Barlow working as a prehabilitation lead, working across Cardiff and Swansea at the moment. So between all of us, we've been trying to lobby as much as possible about prehabilitation and why it's important within cancer. The good news is all that hard work is starting to pay off now, because we have got a prehabilitation for cancer guidance endorsed by Royal College of Anaesthetists, Macmillan, and people like that. Any service specifications that are being developed, there's lots of us sitting on those and making sure that prehabilitation has been included as part of that. And we've also now got national optimal pathways, which include prehabilitation as part of those pathways. Next slide, please. This is just a little bit, and I apologise for those who are on the call. This is a little bit of mapping that we're trying to do at the moment about looking at some of the work that goes on across Wales. There is probably lots of projects within cancer that I have missed on this, but this is just to show you that there are pieces of work going on across Wales about cancer prehabilitation. But for me, there's a lot of siloed pieces of work happening, and now we're at the time now that we really need to look at how can we pull all this together, learn from each other and promote this across Wales so there's equitable access for prehab for all cancer patients across Wales. Next slide, please. This is a slide indicating that there are some collaborative pieces of work happening in Wales now, which is really exciting. So during the pandemic, Rachel Barlow led on a piece of work around universal information available to patients, which we've adopted, a lot of health boards have adopted. As you can see, there's other pieces of work. The Improve project is looking at prehabilitation for gynecological cancers. We did have a lung cancer prehabilitation project that was run across South Wales a few years ago. There's a South East Wales Prehab collaborative being formed at the moment, and there's some other small pockets of funding being used to look at developing resources for patients at the point of suspicion of cancer. So there's lots of really good work happening in cancer services at the moment. A lot of it is siloed, so we are trying to now pull all this together and looking to form a prehab alliance led by the Welsh Cancer Network. So we've got a community of practice, and we can start working together to pull a lot of this together. Next slide, lovely. I'll hand over to Jackie now.
Thanks, Rachel. That was a really an impossible task, but Rachel and I really felt it was important that we, although I'm going to kind of spotlight on what's happening in North Wales, we wanted to kind of emphasise all the other excellent work that is happening across Wales. And obviously we've only got 10 minutes. So, you know, I was asked to kind of provide a spotlight on kind of North Wales. So I'll share that with you now. I thought I'd start by just giving you an indication in terms of the timeline of our work. So this is for rehabilitation for cancer. When in actual fact, back in 2018, there was no prehab services in Betsy Cadwallader at all. But in terms of cancer, a really successful pilot happened in the east area of Betsy Cadwallader. I don't know if people that are not from North Wales, you know, North Wales, Betsy Cadwallader has 3 areas, east, central and west. And although we're one health board, there's often different issues across different areas, but this pilot was led by a consultant anaesthetist, Dr. Neil Agnew, in 2019 for a 6-month period. And that was really the starting point of our prehabilitation for cancer services. And that was for preparations for cancer surgery for colorectal and upper GI. However, it's taken until 2021, towards the end of 21, that the health board actually agreed confirm the funding. We kept having carrots dangled saying it would be funded, but it hasn't been until 2021, and it's been agreed, the funding has been released on a phased release. And in actual fact, in 2022, there's a North Wales Prehab Service Board, which I'll tell you a little bit now about that now. I thought it was important to share this because very much the agreement in terms of funding being released was that prehabilitation services here in North Wales would be overseen by this Prehab Service Programme Board. And the aim of that is that prehabilitation is going to be for all conditions. So certainly our universal and targeted project groups will be focusing on kind of multimorbidity. It won't just be cancer, but cancer will be a large aspect of that. I'm not going to talk too much about them because I'm aware of other talks will give you more information on that. But what I will highlight, I'm going to talk a little bit about, is the specialist service, which is therapy led in the east of our area. Just to highlight really that all of these work streams will feed back up to the programme board. And really important in terms of the release of the funding was that it was aligned under planned care group with an executive programme sponsor. And that has really been influential for us in terms of getting the funding, but making sure there's a pan North Wales approach for all these different levels. So I put this slide in because it was from Dr. Neil Agnew, who has been an absolutely amazing champion and has been the key driver behind getting the project going. He did the initial project, now in terms of getting long-term funding. And so he's kind of really has been the lead for a specialist rehabilitation therapy-led service, which is consisting of high intensity exercise training, 3 half-day sessions per week for 4 weeks, dietetic optimization, psychological support. So that was how the original pilot was set up. And I've just included this. So when we did the pilot, I'd actually only just started in post, so I came in when I was hearing about it at the end of it, and there was massive publicity about it. The outcomes were phenomenal. We had it promoted, you know, in The Guardian, on BBC Wales, actually did a programme, you know, a kind of a highlight on their news. And even though we had these amazing outcomes for patients, you know, reduced length of stay, we had very clear evidence, had really good promotion of what results were, we still struggled to get the funding released. However, as I say, now in North Wales, we have got the funding release for our specialist therapy-led rehabilitation units. There are going to be 3 of them across North Wales, and in each area, starting with the east, which is kind of going to be our flagship, there's going to put down 3 physio, but it's actually 1 qualified physio, it's an exercise physiologist and a prehab assistant with very much an exercise background, full-time. All of these posts are full-time dietitian, full-time OT, which is going to have some links with psychology, very much about behavioural change, and a full-time admin person. So the aim was going to be to have 8 new patients per week in a programme, and it's going to be a 4-week intense programme for those 8 patients. So we're aiming to see about 400 patients per site per year. So that's, you know, obviously 1,200 over the year. And I do think when you're kind of putting in for any funding, it's really important that you do link it in with the numbers of patients that are being diagnosed. So we were able to look at, you know, kind of in the previous few years, how many patients with cancer were actually going for surgery. So we're actually able to get clear figures of who will be coming through the programme. And that's actually really powerful information in terms of persuading funders that you will be seeing, how many patients you will be seeing. I had to put this one up, and I think there's a few people from the team over in our east in the Wrexham area. This is going to be our new venue. And again, we were very fortunate in that we had estates involved in the strategic planning right at the beginning, so that we were able to then get support. I don't know if in other areas, but during COVID, the physio gyms and things like that were taken over. Lots of therapy spaces were used by other services. So we certainly don't ever want that to happen again. So we've been able to get some funding to actually provide the prehab service in a completely different unit. It's very close to the hospital, but it will be away from the main hospital. Previously, the pilot was actually completed in the local leisure centres, but we found they weren't big enough for our numbers that we were likely to see. So I'm going to talk briefly about some of the challenges. I've already alluded to a couple of them. The time scale of actually getting funding released. Even when you've got a massively successful project, it's still very hard to get health boards to release the money, or it was here in North Wales. Engagement of different professionals and different key players. So I've mentioned estates and finance. It's really important that you keep all those people involved right from the beginning. This really is a marathon. It's not a quick sprint in terms of getting, you know, these services developed. And I've also put recruitment down there. As I say, we did the pilot. We had some really skilled staff, but unfortunately, because we couldn't sustain the project, a lot of them actually left and went to, Wrexham is actually fairly close to Chester and Liverpool. They moved on to different posts. And we do struggle for recruitment at times over here in North Wales. So we're very aware of that may be a challenge. And fortunately, the new team, we've been able to recruit to really well, and we've got some really high caliber people joining the new service. Funding is another challenge, as it always will be. As I say, we've had funding secured for the east of our area. We thought we had it for the west and the central, but we've actually been told it's been put on a reserve list. So that really emphasises that we've got to demonstrate the impact of the work that's going to be happening in the east. That is going to be our flagship of excellence. I've also put as another challenge is communication regarding different levels of needs and how to supply those needs in terms of prehab. What I mean by that, while we were waiting for our funding to be released, there is some excellent work happening across Wales, you know, certainly under both Rachels, you know, of kind of providing some really good work in terms of universal levels of prehab. And some of our medical team were hearing about this and actually felt that that was all we needed in North Wales. So it's really keen that the communication goes out there that different levels of prehab services are actually needed to meet all the different types of demand. And no one is any better than the other, but that we all have to work together, which is why we're really pleased that we've actually got a programme board to address that. Sadly, within cancer here in North Wales, a challenge for us is that we have very limited staff to provide prehab, rehab in particular for cancer. It's often provided by generalists, but so it's about how we can support the generalist. And we're really hoping that the provision of this prehab service will highlight and maybe lead to an investment in terms of rehabilitation services as well. Very quickly, because I'm very aware of time. Opportunities I feel have been massive in terms of collaboration and engagement of all professions, not only kind of clinical professionals, but things like finance and estates. Patient involvement is critical. We have got to be constantly showing the evidence of our impact. And as I say, we wouldn't be where we were if we didn't have a champion of our service, a really key player has been our consultant Neil Agnew, who has driven this work. And as I say, we've not got that in the central and the west, so it'll be interesting to see how that pans out. And my final slide here really is just to emphasise really that, as coming back to what Rachel was saying earlier, across Wales there are many different services, and this is partly due to the way funding has been released and different timescales. But certainly the Welsh Cancer Network have are facilitating an All Wales Prehab Cancer Alliance group, which is going to be chaired by our All Wales Cancer AHP lead Rachel Evans. And that will be a great way for us to make sure that even though services may be different, that there is some consistency in terms of standards, and that we are sharing. I do think we actually share incredibly well across Wales, and I've certainly found there's been so much generosity. So thank you everybody for listening.
Thank you both. I appreciate it. It's a really difficult task to put essentially 2 talks into roughly 10 minutes. So thank you so much. Great to hear about the impact in North Wales in particular, and as you said, that All Wales approach, and I guess that honest reflection of what needs to be done to really push for funding. And it sounds like the data you've been collecting has helped that process a bit there. So that's great. If it's okay, we'll hold questions, but I think you might have really helped with some of those key questions that were coming at the end with what you've mentioned here, in particular, Jackie. Can I ask for Claire to come in now and present her work? So Claire's been joint working with Yvonne up in Betsy again, and this is a specific example of Prehab. So I'll let you introduce stuff there, Claire.
So it's really a pleasure to be here. Thank you very much for the invitation. And yeah, I've been working in conjunction with the brilliant Yvonne from BCU, who's on some well-deserved annual leave at the moment. So I'm kind of holding the fort for this. And what we've done, worked very much collaboratively on this prehabilitation program for orthopedic knee arthroplasty patients, stage 4 long waiters. So those individuals that have been waiting for 52 weeks plus. My name's Claire Minchell. I'm director of Joint Approach, but this is something that, you know, my area of speciality, if you like. So we set up this company to be able to deliver this multidisciplinary approach to prehabilitation. So that, you know, on the right hand side, this is very briefly the team. So myself and Mike are co-directors. We have Serena Simmons, who's a lead psychologist. We have then a physiotherapist who undertakes the assessments, exercise specialists, and then we've got the team that sits behind that in terms of tech and project management. This program is all online, okay? So there's a lot of skepticism about whether that could be done and whether it'd be successful. I'll tell you shortly whether it has been. But what we see here is a patient gets triaged into this service. I'll show you the data in a second. They land on a mobile responsive web page designed to be as simple as possible. Nothing's more than 2 clicks away. So it's really, really simple. They have a program of exercise, which is either an exercise video that they can follow in their own time, and that's progressed throughout the months. So it's a 12-week program, or they can choose to join live exercise classes, which are run currently for this cohort 3 times a week, but that grows as more patients come on board. And there's also a section of education. So we talk about osteoarthritis, we talk about pain, and we also talk about mindset. Now that's run by the psychologist, but if we call it psychology, there might be a negative connotation to that for patients. So we call it mindset. And that's all designed to support people to adhere, to, you know, elicit that behavior change, and for them to improve in their function and capabilities as they wait. So briefly, what happens? The clinicians refer into the program. Yvonne and her team did an absolutely tremendous job in selecting those individuals that were right. So there was a inclusion exclusion criteria pro forma. They get referred into the program. We assess them. So it's really important to have these outcomes. We intend to publish those. We've just been working this week actually on some of that data. We assess them at halfway through, and then at the end of the program. The program, importantly, is a strength-focused, high-intensity muscle conditioning program. And that's really important to say. There's also a balance component to it as well. And then in addition to that, we've got the psychology, the mindset, nutrition. And I say in addition to that, the psychology comes first and foremost, because if we don't get the individuals to buy in, we might as well put everything else back in the bin. So it was, as I said, there's a skepticism about whether we could get older people, 60, 70, 80, 85 years old even, onto Zoom, onto online programs. This was captured with consent, one of the live exercise classes, and those individuals in those groups absolutely love them. So let me tell you about how we got the program up and running. There were 146 sets of notes that were screened, and then according to the eligibility, ineligibility, they were then either eligible or ineligible. Interestingly, the majority of those ineligible were due to the fact that surgery was either just about to happen or already had been performed. Then those individuals that from the notes that were eligible then went through another process. So they were then telephoned for a telephone screening. Of that, I'm whipping through this because of time, 46 of those individuals consented and were appropriate for the program. 31 consented and were inappropriate for the program. And the main reason for that was lack of internet access. Now, we have got a solution for that we can implement, but and I think this percentage matches, I think it's around about 17% on a total population basis, which I think is about matching that of the Welsh population. And we get those individuals we couldn't contact and some that just declined off the bat, which is perfect because this is not a one-size-fits-all program. And those individuals that are ineligible went into a monitoring group. So again, from an assessment perspective, this has been really, really important to see how those individuals in the monitoring group perform compared to those that were put into a prehabilitation. And there's just then that one extra touch point. People came in for a quick measurement of BP and BMI. At that stage, there were a couple that were excluded. So that meant we have a total group of 44 there. So in terms of what we're recording, so objective data includes pain, function, PROMs. We're also looking at analgesia use and adherence, and we're taking that data, comparing it to the monitoring group. There's also another layer of analysis, if you like, and evaluation, which relates to this qualitative data. So that's really investigating the patient's lived experience, which is being led by the psychology lead, Serena. And we've also got this length of stay post-operatively as an outcome measure as well. So we're able, when Jackie was saying before about looking at kind of the impact of that, that's something you can really attribute fiscal value to. So what we're doing here with this data, we're comparing it to the monitoring group, but as we accrue more and more data, we'll be able to develop a profile of those individuals who are the best responders, if you like, and most appropriate for this program, and those who are most likely to do well. So current status, we're about 3/4 of the way through the interviews. We're almost at the end of the program, so there's a few people still waiting for surgery. The feedback, overwhelmingly positive. It's honestly, when you actually listen to people, it's heartwarming. People are thankful for the opportunity. They've, anecdotally here, dramatically improved and increased mobility and function, and sometimes that can happen within 2 weeks, which is interesting. You see these dramatic changes around 6 to 8 weeks, and then again latterly. And something I guess that was just brought up, there's a surprise. They were surprised by the lack of provision previously about education and education around exercise in particular. Some of the statements that are really heartwarming. It's given me a purpose. I've walked further than I have in years. Some guys managing to do 12 miles a day for a few days a week on his bike. And bear in mind, this person has been waiting for over a year for a knee replacement. So, that's profound. And just last week, we're actually at some of those patients' houses doing, and this is all with consent. There's plenty of consent forms, and we're developing videos to help portray that important patient experience to the commissioners, to individuals, who are contemplating implementing this, but importantly for the patient themselves to understand what that is. We've got some brilliant pictures here and professional videos will come down the line of, you know, a lollipop man doing his exercises whilst working, and this lady couldn't even walk up the stairs before she did the program. So in terms of the data, we're still bringing all of that together, but I just wanted to show you how it's looking in terms of the profile. We should have the full data set by the end of this month and be able to report back on that. So some of the outcomes here, so pain as assessed on a VAS out of 10, baseline here is 6.7. There's a big range there. There's just plenty of people reporting a 10 out of 10. So remember, this is group mean data. We've also then got seen a nice profile of decline in experience of pain. And again, we see a big difference between individuals as well. So we're looking at the percentage change by individuals as an index as well, but clearly a clear profile towards improvement in pain. And that's alongside as well these reports of people self-selecting to take themselves off medication. So many people have reduced by half their use of analgesia. So the fact that pain is reducing as well as reducing analgesia is a really profound thing. And had we not got some of this qualitative research going on there, then we would lose that information. Functionally, sit to stand, that's improving dramatically in the exercise group. We're taking some measures of COOs as well. Quality of life, one index here, that's improving as well. And I just wanted to show you how this looks. I mean, it looks great on balance here with the exercise group. And we're saying patients are waiting well, but importantly, it's the patients on the program that are waiting well. This data is really surprising to us. If we look at the monitoring group here, my assumption would be that these individuals have been waiting for a long time, often more than a year, and how long it takes to get onto that waiting list. So in my view, a lot of that deconditioning will have already happened, and their experience of function loss and pain increase over that 12-week period only probably would be very little, if any at all. But we're actually seeing, for example, an increase still across that 12-week period in experience of pain. And if we look at function as well, again, the same profile. So whilst the Prehab group is improving, so pain going down here being better, and then function going up here being better, we're seeing the equivalent decline in performance in the monitoring group. So that's a pre and post 12-week assessment there, which, as I said, that's quite surprising. In terms of the length of stay data, we're still trying to mine that data. We've got examples of what it was pre-COVID. So post TKR, the average stay in BCU was around 4.3 days. Post-COVID, when surgery was reinitiated, that's gone to 5 days. We've got 3 data sets from individuals, although we know most people have had surgery now, so we're just accruing that data. But on those 3 data sets, we've got an average length of stay of 3.3 days. So I'm very hopeful that we can match pre-COVID levels and actually potentially even exceed that. And not only is that a very calculable cost saving in terms of bed days, it's also freeing up surgical capacity as well. And importantly for us, the patients are feeling really well to go home. So Datum Projections, we think that this programme is likely suitable for approximately 60% plus of the eligible population. We have a solution that we can use for those individuals that don't have internet that we're able to deliver to them. Engagement in the programme is very high, so people are actually really motivated to do well, which is fantastic. And again, something that might be quite surprising. We're expecting very good outcomes based on these interim data. And it might be a possibility that we can perhaps expand these inclusion-exclusion criteria as well. So to say, you know, in where this program fits, we're clearly at this prehabilitation, pre-surgery time phase. But prehabilitation, as we've just heard, can fit anywhere on that pathway commensurate with what that patient is then going to encounter. So it could be prehabilitation prior to kind of continuing in normal activities of daily living. So this actually fits along that pathway. And where we're at right now, we've got a case that Yvonne and myself have been working on that's currently being evaluated to scale this across all of North Wales at that prehabilitation population. So to try and deliver that more widely, given the fantastic results that we're seeing. And we ourselves are really interested in trying to kind of collaborate with others across Wales if this was of interest to you. So I'll stop talking there. Hopefully it wasn't too long. And yeah, thanks so much for your attention.
Thank you, Claire. I think your presentation and Jackie and Rachel's now, the questions are certainly coming through the chat there, and actually they're quite specific to yourself. So I don't know if you have a chance to answer any of those specifically.
I'd love to. I don't have access to a chat box, so I don't know why.
Okay.
Forgive me. I'm so sorry.
What we might have to do then with time, if that's okay, is put them to you after, or maybe at the end if we get time, and then we can see what we can do. Is that okay?
Yeah, or email as well.
Yeah, I know I've got particular questions as well, so I'll I think time will beat us. But thank you. Okay, so can I ask Ben and Catherine to present next? So Ben and Catherine are from Orthopaedics in Hywel Dda, and quite recently or last year were recognised alongside the work with Maralise, who's also here as part of our panel in London with through the digital healthcare show. So, and I'm going to assume another digital format as well to present in prehabilitation.
Okay. Hello everyone, thank you for joining us today. We're going to talk to you today about our new virtual orthopaedic prehabilitation service. So my name is Catherine and I'm the clinical lead occupational therapist for the service. My colleague Ben is here with me today, who is the clinical lead physiotherapist for the service. And we have Maralise on the panel, who is the improvement and transformation lead for Hywel Dda and leading on this project. So I'm going to start off in true MDT style and start the presentation, and then I will let Ben finish. Okay. So the main reason for this introduction was due to the impact the pandemic had on the elective waiting list for total hip and total knee replacements. It's been funded by Welsh Government. So the project has had an holistic MDT approach. So we have a physiotherapist, an occupational therapist, dietitian and psychologist within the team, along with 2 physiotherapy technicians as well. So due to the ageing and large geographical area of Hywel Dda, the idea was to target more people across the 3 counties and standardise the care we give. So just to give you an idea, sorry, I skipped there. So just to give you an idea of how many people have been affected, we've got over 4,000 people on the waiting list at stage 4 for elective surgery. So with regards to its delivery, we had 3 tiers to how we wanted to support patients. So tier 1 was an 8-week prehabilitation programme, which we put on a digital personal held health record. Tier 2 was a virtual group prehabilitation supported by technology enabled care. So this was 12 sessions over 12 weeks. And then we had tier 3, which was a virtual one-to-one session for individuals with more complex care needs or not suitable for group consultations. So the tier 1 digital health record. So this was for patients not suitable for our 12-week programme or needing one-to-one support. So they were signed up for our PKB. So this was offered to priority 2, 3 and 4 patients. So we had a mass registration process where we sent out letters to all the priority 3 and 4 patients with a unique code on the letter, which gave them access to the PKB. So PKB, so it's a personal digital health care record that patients can sign up to. And we developed an 8-week care plan on this. So this included elements such as education, exercise videos that they could follow, and different elements of prehabilitation. So it also included different resources they could access within their own time. So tier 2 was the virtual prehabilitation delivered in partnership with Delta Wellbeing and Tunstall Healthcare, and we offered it to priority 2 patients, therefore the ones who were identified to come in for the earliest for their surgery following the outcome of an individual MDT assessment, clinical need and shared decision making. So if I take you through quickly now, I'm going to hand you over to Ben, who's going to explain the development and implementation of the service.
Right. Quick change around. Hi everyone. We've broken it down to 5 steps. So step 1, the first step was looking at the governance, reporting and evaluation arrangements. We looked at what training the staff required, as we were new to working with virtual platforms. We agreed the prehabilitation bundle we wanted to use, so weigh and scale, heart rate, oxygen saturation and blood pressure monitor. We also developed a decision tree which allows us to monitor the patients twice weekly and allows us to clinically escalate then if appropriate. We also developed an MDT assessment template to assess the patient's needs and thereby decide which intervention was most appropriate for them. The ones we identified that were suitable for Tier 2 prehabilitation, supported by tech, we uploaded them on the Tunstall My Mobile platform, as you can see here, which then triggered off a referral to Delta Wellbeing. And Delta then arranged to deliver the equipment and educate the patients on how to use the equipment and the virtual technology. We also had the option to provide patients with digital devices in order for them to be part of the programme, and Delta also offered ongoing digital and equipment support throughout their time on the 12-week programme. The patients attended virtual group prehabilitation sessions once a week, and we asked the patients to do 2 readings per week, which were uploaded to the My Mobile app. The Tunstall platform collects the remote monitoring data and manages it within set parameters, and with us and as the clinical team, we were able to kind of monitor the platform and contact the patient if indicated. We also uploaded weekly exercise videos and resources on the app so the patients could access, and we could also interact with the patient through the messaging via the app. And on completion of the 12-week programme, the equipment was collected, cleaned, checked and stored by Delta Wellbeing, so the equipment can be reused for the next patient cohort. The information stored on Tunstall platform, we can export that data to be filed in the patient clinical notes, and the patients then were offered ongoing nudging via messaging to continue their health optimization. So some of the learnings, some of the things we learned from developing and implementing this service was that adopting a virtual first service model helped facilitate the use of digital solutions to prehab. So, you know, virtual was our kind of default setting. Partnership with Tunstall and Delta Wellbeing was needed to successfully implement kind of digital solutions, and it did also kind of release clinical time. We were fortunate that members of our team bought into the virtual concept, and this was key to the patient buy-in and engaging within our programme. You know, we also had a very high compliance rate with the remote monitoring, and patients felt like almost reassured that clinical staff were monitoring their data, and you know, it did contribute to positive patient outcomes. Like Claire said, age was definitely not a barrier to digital solutions. You know, we had patients from 92 years of age to patients in their 50s involved in the programme. And, you know, by doing the assessments, we also realised that, you know, face-to-face appointments led to kind of exclusion, not inclusion for patient, because a lot of these patients are, were unable to travel a lot of the time. They were housebound, and would have to be reliant on people to get them to appointments. So to date, currently we've had 67 patients have been through our 12-week program, and the aim is to increase capacity. 7 patients who never used technology before were provided with tablets or equipment, and this successfully supported them to start using digital platforms. The evidence is showing that remote monitoring platforms supported by clinical team leads to behavioural change and improved physical and psychological outcomes. And all stage 4 patients awaiting hip and knee replacements have been contacted by the health board with an offer of prehabilitation between April and June of this year. So I'll let you kind of read the presentation. Yeah, this is some of the feedback we've had. We've had a lot of positive feedback from patients. From improving the patient's health and supporting them while they're on the waiting list, waiting for their surgery, and also for introducing them to virtual technology and the benefits of digital monitoring. And this is actually my feedback. So I've been working in elective orthopedics for over 15 years, from the pre-assessment, the ward, outpatient and orthopedic clinic setting. So I felt I knew this particular patient cohort very well. And prior to beginning my role, I was very sceptical about the patients taking up the virtual part of the service, and felt it would be limited. However, I have been pleasantly surprised that a lot of patients already had the skills and equipment for virtual consultations, and for the ones that did not, a good number of them were eager to learn new skills to be a part of the programme. And on the whole, all staff within the service have had a positive experience, and that's why they all want to continue within this service. Thank you very much. And I will.
Thank you both.
Thank you very much.
That's absolutely fantastic. Thank you. I realise I've probably been a little bit overconfident with the timing, so we're a little bit short of time now. But thank you, everyone. I think that was, and I really liked the end part there, Ben and Catherine, with regards to sort of understanding how you've met people's needs as well. That was really nice. What I'll do, I think, because Jackie actually touched on the sort of the challenges and benefits with regards to resource and planning, with regards to space and finance and so on earlier. If I reprieve that question that I was going to give to Maralise, if Maralise is okay for that, we'll see how time goes. Can I go to one of the questions that's really one of the strong questions that's come from the information that was sent to us prior from you all, to Hugh Davis, who's working in Cardiff and Vale, and Rhys Jones, who is working in for UK Leisure, and working closely with Hugh as well with regards to developing rehabilitation and prehab in the community. I think one of the questions that I noticed as a theme was very much about how do we support that movement into the community with regards to prehabilitation, and I wondered if Rhys and Hugh, as one of our few of our panelists, wouldn't mind sort of chipping in on that.
Yeah, do you want to go first, Rhys?
Yeah, sure. Thanks, Catherine. So yeah, my name's Rhys Jones. Just to say that even though I'm working in Cardiff at the moment, running the 8 leisure centres for Cardiff, I'm here today representing Community Leisure UK for Wales, who are the body who represent the culture and leisure trusts across Wales, and it's 11 members working across 9 different authorities. And yeah, I really took on board the comments around sort of the how we bring this to life within communities. And in Cardiff, the work we've been able to do really revolves around a really collaborative approach between us and Hugh's team and the health board. So what we've got in our leisure centres is big spaces, and I was interested to hear that space was an issue in the other presentation. We've also got a lot of staff as well who we've been able to upskill, and that collaborative approach with Hugh's team in terms of upskilling staff within the leisure centres to, in some cases, co-produce some sessions, things like escape fitness, escape sessions, escape pain. So that collaborative approach is really important, and the idea with bringing it back into community venues and community facilities, you know, usually people have less distance to travel, a bit more local to them, and they have an opportunity to meet people in their local community and build up that sort of social rapport with other people and create almost communities within the buildings. Funding it is obviously a challenge. One of the ways to be able to do that in Cardiff is to come up with an affordable membership option, but also a pay-as-you-go offer, so people are able to afford these things. So some of them are obviously still free through the NHS, but the goal is very much around trying to get repeat usage in facilities to try and make sure they continue their health and wellbeing journey. So there's a lot of kind of brief information there, which I'll be happy to touch on and deep and go into in more detail offline if anybody wants to contact me. But you know, around the venues across Wales, and that's 115 venues that we've got for community facilities. There's a lot of opportunity there for leisure and cultural trusts to collaborate with the NHS Trust to try and explore ways and really collaborate together to bring some of these things to life. So sorry, getting a bit of a touch on a lot of things there in that answer, but I don't know if Hugh's got anything to add.
I was just going to add around how important the co-production has been, because it's enabled us to not only co-deliver the programs out in the leisure centres, which has enabled us to really scale up the services that we've been putting out in Cardiff and the Vale, but also it's helped us to be able to provide what our follow-on groups that you've touched on, which for our escape patients are our escapee groups, where they can continue the work that they've been doing out in the community, and they can continue to access activity beyond the programs that they're on.
Brilliant, thank you both, and I appreciate. I think really hard to answer that question in a couple of minutes. I'm sure others have got far more they'd like to add to that as well. Can I move on to one of the other big themes then, as well as resource? That then the next theme that came about for me was about that buy-in for workforce and for the people engaging, and I kindly delegated that to Rachel Evans from the collaborative. Rachel, are you still there? Sorry.
I am. Hiya. Hi all.
Yeah. Would you mind coming in? I'm conscious of time. People do need to leave at bang on 11:30. Obviously, I do appreciate that. And just to say that what we will do, we'll collate a lot of this information, bring it to the planned care programme, and present this back to you all and others, just to let you know. But we will do our best to answer the questions in the chat as well. But if people are able to stay on, we can carry on for a couple of minutes. Go on, Rachel.
Thank you. So I think a lot of it has already been covered very eloquently by Rachel and Jackie in their presentation. So I'm the AHP lead for the Welsh Cancer Network. So in terms of prehab in Wales for cancer at the moment, it's a very hot topic. We are supported by a lot of national documents, which I think really helps our drive for change. Prehab is everyone's business, so it's a very inclusive concept by nature. The fact that we've now got high-level buy-in from the Cancer Board supporting an equitable approach to prehabilitation across Wales, that's really going to help our sort of impetus and driving for change. We need to align our standards with kind of what's going on nationally and what is best practice. And I think if we got kind of an equitable all Wales approach, it would really put Wales at the forefront of prehabilitation. And so I think that's, quite a nice kind of incentive for people to align with it. In terms of what's going on at ground level, I think the ability of teams to really be able to clinically integrate, as AHPs, sometimes our profile can be a little bit elusive. But I think if we're there at the front door proving our worth and working together, that really demonstrates how we can be effective and how we can improve patient outcomes and be very much stronger together. I think there's many things that we can sort of pull together: patient data, both qualitative and quantitative, the evidence, the national documents. It all sort of forms a bit of a jigsaw really in terms of proving a case that's hard to ignore. I think we need to get the medical people on side. Thankfully, with Prehab, I think they very much already see the benefits of it in cancer. But I think if they're promoting it to patients at an early level, that really helps the buy-in and proving the worth. I think as AHPs, we really need to raise our profile, start podcasts, education stuff. There's so many ideas just to get us at the forefront of ensuring that we're very much thought of when it comes to prehabilitation. And then the education side of it is, it's a really meaty question, Gethin. The education side of it, both for AHPs that don't necessarily work with cancer as well as patients. So we need to sort of go on road shows, participate in conferences, just take every opportunity really to bang the drum to show the difference in what we can do and how we can do it. And then finally, I think we need a very strategic and systematic approach, which I guess is where kind of the Welsh Cancer Network comes in with the AHP leads, just making sure that everyone has time to do the sort of research and innovation, breaking the background of sort of a vicious cycle that has, previously put us on the back foot, really. If we're there in the evidence and we're there in the guidelines, it'll be much easier for services to have our backs and for us to be commissioned as standard to provide those services. Hope that answers your question.
I think it did very well. Thank you, Rachel. I'm conscious. I'm thankfully there's quite a few people still left in the chat. If people do have in the session, if people do still have time, I'm wondering if I could go back to Marlies with that question on any additional thoughts there, Marlies, on supporting people with regards to resource, space, training, time, really, and that sort of use of the team with Ben and Catherine there, and how you kind of went about that, if that's okay.
I think in terms of space, I think there is a general lack of space on acute hospital sites. So I think the drive to put things into the community or virtual delivery models, I think most patients probably do not want to go to an acute hospital site for intervention if they don't have to. I'm not sure if it's similar to your site's parking this issue. So I think there's a lot of community halls, the leisure centres or virtual models. So I think in terms of space is thinking slightly outside the historic box. So we need to find different ways to address, and also how we reach. We have, similar to BCU and other places in Wales, very rural population. Even leisure centres is not suitable for a lot of our population. Like Ben said, a lot of patients actually were excluded because we only offered face-to-face solutions pre-COVID. So I think we need to adapt our service delivery and our venues to our patients, either that be virtual or at their home or in a hall suitable to them outside the acute hospital settings. So I think in terms of resources and training, I think for us it was probably not so much the clinical training. It was the use of different models of service delivery, virtual group consultation, using attend anywhere groups, using remote monitoring, the Tunstall platforms. So I think it is essential when you set up Prehab services to phase them and actually make sure that when you have a delivery plan that you deliver against, it's not just let's start tomorrow, it's plan it. So when your outcome measures, your evaluation, everything is in place, as well as your reporting structure. I've had a lot of the conversations about funding and long-term funding. This needs to deliver outcomes. So having a measurement platform and evaluation around your service from the moment you start probably will be important for that longer term conversation, because we're all fighting for the same funding pot across NHS Wales. So I think it's actually what adds value, not just another service. It's a service that adds value for the patients and the services. Not sure if that answers your question, Gethin, but I think building training into your service delivery planning when you're setting up Prehab is key, because once people start seeing patients, there isn't the space in the headroom to actually get those things going.
Well, that's absolutely fantastic, Marlies. I'm so glad I came back to you, even though we're running late. Okay, there's so much chat and discussion and questions in the chat. I will bring that together and get that to you guys, and make sure the people who've been asked about questions, we get those answers. As I said, we'll be going back to the planned care team with this information on top of what they've got in their recent carousel session, and hope to move this forward from a national point of view. But great to hear about interest from a vascular point of view in the chat there. I think highlighting that inequality between different formats as well and how we can improve that. Yeah, just really excited to hear this. So thank you so much for all attending. Thank you to the speakers and the panelists, and Abby and Ross for helping with the admin and the chat. And look forward to moving this forward. Thank you all.